Right, Dr. Rice, I think we're all set. You wanna
Okay. Awesome. Okay, we'll go ahead and call the meeting to order now. First, just a couple of housekeeping things for those of you guys who don't use Google Chats much. At the bottom, there's a little bar. You can hover over to mute yourself or turn off your camera. Just make sure you're muting yourself if you're not talking, because when we have 35 people on the meeting, it can get a little distracting. If you're on the phone, it's going to be *6 to unmute. As Shelley mentioned, we're recording the meeting today, so anything you say or put in the chat will be recorded as well and part of the recording, posted to the website. You don't have to present your screen. Shelley will be able to do that for us. And please make sure you identify yourself before you talk, so that we all know who's talking. Sometimes the internet gets a little choppy and it's hard to tell who's speaking. I guess we'll start off with the roll call first. Shelley?
All right, thank you. Amber Rice?
Here.
Brian Smith?
Present.
Chester Key? Ed
Shelley, he's
Missoula?
trying to Miller right now. He's trying to log in.
Oh, all right. The key is on the way. Ed Missoula? Joshua Gaither?
I'm here.
Chris Long?
I'm here.
Thank you. Matt Shaw?
Present.
Orlando Alcordo?
Present.
Ryan Harold? Sandy Nygaard?
Present.
Sharon Hollingsworth?
Present.
Stevie Merrill?
Chester Key is online.
I count 10. We do have quorum.
Thank you, Shelley.
Sorry about that. I couldn't get it unmuted. I'm here. Sorry for the delay.
Thanks, Stevie. Okay, so first up on the agenda today is going to be the chairman's report. So attachment, in the attachments that Shelley sent out is the attendance report, just to make sure that you remember that if you miss 2 consecutive meetings, you'll be asked by the Bureau if you'd like to continue serving on the committee. And then for vacancy report, there are no new members, and we have 1 vacancy, I think, for a PACES representative at this time, if the roster gets updated. We have a upcoming item to discuss the roster. If that gets updated, we'll have a vacancy, but as of right now, there's nothing.
Hi, Amber, this is Dale. Just to let you know, this afternoon during the PACES meeting, this is on the agenda to offer up a suggestion for a PACES member.
Okay. The next up on the agenda is going to be the Bureau report. So I have up is Julia for EMS for Children.
Good morning. The biggest update is we do have some upcoming data collection for the National EMS for Children program that will be starting in January and going through March. It'll be the same survey that was conducted this past year. Also, the PACES group has worked really hard on creating a safe sleep module that is ready for review. So that will be reviewed later on in today's meeting. That's all.
Thanks, Julia. And then I think next up, Ben will talk about some opioid and cardiac arrest data from the Bureau.
Julia, I'm just going to share my tab real quick. We have been monitoring some data during the COVID period, and I know this is kind of interest to everyone. The 2 that we're highlighting today are opioid use or suspected opioid use and cardiac arrest. The case rate per 100,000 of opioid use over the summer has increased pretty significantly. There are some kind of appropriate causal theories about what's happening there with people not having access to treatment or being at home and during the quarantine period potentially using opioids more. That's something we're continuing to track, and as we get additional data, we will present it as well. The other data that we we know is kind of interest and have been asked about is cardiac arrest data during the over the summer. From January to July, this graph just goes through July. It increased pretty substantially, and then July was the dramatic spike in cardiac arrests, including cardiac arrests that were pronounced on scene and not transported. So in the graph on the right, you can see that the patient disposition of dead on scene increased pretty dramatically in July, and transports dropped pretty significantly. That is also something we'll continue to monitor. We are continuing to collect additional data. I should say that because this only goes through July, the rate has decreased. It is still above the previous 2 years, but it is not quite as dramatic as it was in July. And obviously with the sort of impending increase in cases coming, that is something we'll be watching pretty closely. That's all I have for those two presentations, Amber.
Thank you, Ben. And then next up, I have the regulatory and bureau chief update.
Dr. Bradley, we are not able to hear you if you are speaking.
Can you hear me now? 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 Can you hear me now?
Nope, we can see you talking, but no audio.
How about now? Can you hear me?
Yeah.
Okay.
Sorry,
there's a little bit of feedback we're going to try to figure out here. Well, hopefully there's no more feedback.
Try now. Nope, still muted.
Are you able to hear us now?
Yes, but there's feedback.
All right, how about now?
That's good.
Sorry, we're trying to turn off what was working really well for our last meeting. Are you guys able to hear me now?
Yeah, your audio's great now.
Excellent. Okay, sorry about that. We just did not want to torture you guys with the audio feedback there. So apologize for that. Technical issues that we keep working through. Anyhow, we just wanted to say thank you to everyone for participating today. I know remote meetings are not the easiest, hence our little IT issue that we just had. But we really appreciate, it looks like we have close to 50 people participating in today's meeting. So thank you guys for joining us today. As everyone knows, Terry moved to Montana and left the Bureau of EMS recently. And after a really big search, I just wanted to welcome Rachel Garcia as our new Bureau Chief. We're really excited. This is her first week. She started on Monday with the Bureau, just in time for all of our standing committee meetings. So I'm going to hand it over to Rachel to say a few quick words.
All right. Good morning. Can you hear me? Hopefully there's not too much feedback. Good morning, Dr. Rice and and all. I'm happy to be here. I understand it's big shoes to fill with Terry's departure. I've been with ADHS since 2019 as a Deputy Bureau Chief, working in public health emergency preparedness. And I just want to thank you all for your patience as I transition into this role and we navigate this new virtual environment that we're in. I'm going to provide a very brief update on our COVID-19 response here at Arizona Department of Health Services, and then I'll turn it back to Dr. Gale for some additional updates. As of today, we are at over 287,000 confirmed cases of COVID-19, and as you all know, our numbers are going up right now. We have two of our key benchmarks suggesting substantial spread statewide. So we continue to encourage mitigation measures. Today, hospitals are reporting ICU and med-surg capacity at 89%. And so our EOC and the surge line are in communication with our hospital partners, and we are tracking facilities that are reporting staffing issues. I know we're all looking forward to Thanksgiving next week, and ADHS has provided recommendations on how to have a safe holiday with families. Yesterday, Governor Ducey and Dr. Kara Christ also held a press conference and made several announcements related to providing testing support and resources at airports, masking at schools, and additional staffing resources for hospitals. They also announced in an executive order was issued an enhanced surveillance advisory for providers that will be providing immunizations as part of the COVID-19 response. There are specific immunization reporting requirements that are detailed in that executive order. And ADHS is also in the process of renewing EMS waivers to continue to support the COVID-19 response. So we'll make sure to keep our partners updated on that. I really look forward to participating in these meetings moving forward, and thank you all for letting me participate. I will be available for any questions. Thank you.
Thank you very much, Rachel. And then we have next on the agenda for the Bureau report is the COVID-related initial and ongoing certification issues.
Yes, can you guys hear me again?
Yep.
All right, perfect. So we just wanted to bring this up. Certainly with the Education Committee, we recognize that many of you are key partners throughout the state of Arizona when it comes to both initial and ongoing certification. And we just wanted to see and get feedback from this group in terms of any issues that are ongoing in terms of getting personnel through their initial certification program or ongoing recertification requirements. So we just wanted to briefly open that up to see if there was any feedback from this committee that we needed to move forward as the Bureau.
Hi, this is Chris Long. I'm in Kingman, Arizona with Mojave Community College. And from the initial certification perspective, what we are seeing is, unfortunately, with having to do a lot of our lecture stuff via Zoom technology, our students are really struggling with that and with the ability to grasp and, ask questions, even though we do allow them to ask questions that they're just not doing as well as they do in the classroom. And from the certification side of it, the lack of available testing centers for them to take their written certification exams through the National Registry of EMPs. Right now, for the Kingman area, we have very limited access to the college testing sites. Most of our students have had to travel to Vegas, Flagstaff, or Phoenix to be able to test.
Thank you for that feedback. There is a question in the chat box from Kim Wright asking regarding how many extensions are going to be allowed. We do not have a definitive answer to that. Part of this is up for what is approved at the governor's office. Certainly the goal is to maintain as many people being able to work and maintain our workforce for EMS throughout Arizona, but we don't have a definite amount of time that this will be extended.
Dr. Bradley, is there a Kepler?
Go ahead, Eric. Thank you.
So yesterday we had the GCC Paramedic Advisory Council meeting, or that they do like quarterly or whatever. And just, I'm sure you're aware of it, but one of their concerns or their issues is the uncertainty of the clinical times, right, for people. I know we're in there now, but obviously at any moment the hospitals could reverse that type of stuff. So I think that's just one of the things, the concerns out there, And then they're having issues on vehicular stuff for the non-fire or EMS agency private ambulance cohort. So if it's a pure, just cohort that's just not related to fire department or EMS, then vehicular times are issues for them because we're not, everybody's shut down and we're not even allowing our own, members' families to come into fire stations, let alone people on vehicular. So I think those are some of the challenges that I know they're facing on the education side. So.
Yes, definitely. Thank you for bringing that up, Eric. Any other comments or feedback? We really appreciate you guys speaking up because definitely these are some of the things that help us when we go and request extension of different rule waivers. So please let us know if you have any issues or concerns. We can certainly move that forward.
Gail, this is Sandy. Currently, all of the Banner hospitals are allowing students in, kind of sharing them. So if they have students, typically they stay in their own sort of little pod. On the Glendale side, they usually end up at, Estrella and Thunderbird. But we're trying to spread them around. So if students don't mind traveling, we may be able to fit more of them in some of the slower facilities that don't have as many educational places around them. Just a thought.
No, that's a wonderful resource, Sandy. Thank you for bringing it up.
I know in our area, we've had a little bit of difficulty with the current students getting enough PEDS contacts on their clinicals.
Any other feedback for us? Great. We really appreciate you guys all speaking up and giving us that information. And I think I will go ahead and pass it back to Amber unless anyone has any other topics to discuss.
Awesome. Thanks, Dr. Bradley. So the next up are a few action items that we have today. So if I could get a motion to discuss the education meeting minutes.
So moved, Brian.
Seconded, Chris Long.
Thank you, guys. So displayed right now are the education meeting minutes from the July meeting. They were also provided as an attachment for your review. So after you've had a chance to look it over, if someone has a motion to approve the minutes.
So moved, Brian.
Second, Orlando.
Thank you. So all in favor for approving the July meeting minutes as written, say aye.
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 Any opposed? Any opposed, say nay. Okay, we'll move on to the next action item. This is going to be for the bylaws updates. So provided as also as an attachment are the recommended updates to the bylaws. The only recommended changes are in the roster section. So in an attempt to make sure that all the regions are represented and we don't have competition for certain spots by different regions, these were the recommended changes to the roster. So one was the creation of an NAEMSP representative, and this would be just a change. It would keep Stevie Merrill in that position, and then the creation of a pediatric advisory or PACES representative from the PACES standing committee. So those were the draft changes. I don't know if anybody else had any other comments or recommendations. If not, we could also take a motion to approve these changes.
Move to approve.
Sandy will second.
Okay, all in favor of approving these changes to the roster for the standing committee bylaws?
Aye.
Aye.
Okay. Any opposed, say nay. All right, thank you all. The next item I have up on is to discuss the medical decision-making and capacity education module. So Dr. Merrill was very kind to review this for us and provide some recommended edits. So we can, if we get a motion to discuss this, I can kind of take you through the recommended changes.
So moved, Brian.
Second, Matt.
Thank you all. So I think the first change was just on the sort of, I think it was the 13th slide. Just defining that abbreviation DTS and DTO. The second recommended change was just a typo, oximetry on slide 22. Slide 28 and 32 both have these big pictures on them that when you try to download the slides or open them in other programs other than PowerPoint, makes it very difficult to view them. So my recommendation was just to remove those photos off of there so that they weren't becoming a distraction or creating issues with people downloading the slides. The next one was slide 48. So the previous verbiage is there sort of crossed out a little bit. This it just said proxy decision maker on it. So the way it was written seemed to be confusing. So the recommended change that I put in there was just to make it a little bit more clear what we were talking about. So definitely open to suggestions on this verbiage. I just wanted to clarify. And so it kind of goes with the slide below it. So that US law and state law issue, this one kind of talks about the specific surrogate or proxy decision makers for Arizona. So it kind of goes with this slide, but the one above it is the one where the verbiage is changed to sort of clarify what a proxy or surrogate decision maker is. Are there any questions on that part? The next one that's it. So those are the only changes that were recommended in the slide set. So I'll open it up for additional discussion if people have other comments they want to make or recommendations.
Hi, it's Brian.
Hey, Brian.
Hi, a question. There's in here there's a reference to the statute on HISI use of force. So that only deals with that particular instance, immediately stopping someone. In that same chapter in the criminal code, there's also a reference about being able to, it's basically a statute that you can use in order to take someone against their will when they don't have decision-making capacity, although it's written to say competent, but you know, that's lawyers and people in the legislature. And I don't know, maybe it would make it too confusing. I use that when I talk about this topic so that people understand that when they take somebody against their will under the order of a physician, when they think they don't have decision-making capacity, I hear the word kidnapping a lot. And that use of force is actually the precursor to a kidnapping. But that chapter is about justification for the use of force. I just wonder if it would be beneficial to have that in here so that people can see that there is a process in order to be able to use force against people, and they're protected under the statutes in Arizona.
I was just looking for that statute.
It's 13-403 C, and I think it's 4 or 5.
403 or 404?
Should be 403.
Hmm.
Here, let me get a different.
Do you have a suggested verbiage that you would recommend?
Well, I kind of was working on this a while ago and was working on how to get that in there so that it would be meaningful, and I kind of got stuck and got other things going where I didn't figure out how to get it in the slide pack. Were you able to find it in 13403?
Yeah.
Let's see. I think it's 4 or 5.
Yeah. So
it says under the order of a physician or a nurse, a person may. And then it goes on to talk about, if the person isn't competent.
And I think this is the part you're referencing. A person responsible for the maintenance of order in a place where others are assembled. Hold on. Or a person acting under his direction may use physical force if and to the extent that a reasonable person will believe it necessary to maintain order. But such person may use deadly physical force only if reasonably necessary. And then a person acting under a reasonable belief that another person is about to commit suicide or inflict serious physical injury upon himself may use physical force upon that person to the extent reasonably necessary to thwart the result. A duly licensed physician or a registered nurse or a person acting under his direction or any other person who renders emergency care at the scene of an emergency occurrence may use reasonable force for the purpose of administering a recognized and lawful form of treatment which is reasonably adapted to promoting the physical or mental health of the patient if the treatment is administered with consent of the patient, or if the patient is a minor, with consent of parent or guardian, or the treatment is administered in an emergency when the person administering such treatment reasonably believes that no one competent to consent can be consulted and the reasonable person wishing to safeguard the welfare of the patient would consent. Is that the one you're referencing?
So
we probably we could place the reference to the statute in there, or
and just, Brian, this is Gail. Just to clarify your questions, I think I don't know that 405 would apply because that really is use of kind of deadly force, which I don't think we're talking about. But the 403B, I think that's where they use competency versus capacity. I don't know that we'd want to add it on this slide. It might be reasonable to add just somewhere else in the lecture. The only part that might be a little bit tricky is we focus so much in this lecture about using the term capacity versus competency. I don't know if that would confuse people more.
Well, that's, I get that. And, I have the opportunity to explain why that is written in there like that when, the people who wrote that statute aren't clinical people and don't get the difference between a clinical assessment and just using the word competency to cover everything. So, and it's 4035, that whole section kind of applies as 4035, and it's a use of force. It's not, it doesn't say, it's not in the section on deadly force. That's just force. So I don't know I'm not saying it needs to go on that particular slide with a HISI. It may be someplace appropriate somewhere else, and maybe then it needs a slide to explain it. I don't. It's just a thought I had, and it may not. Maybe it's too much to go in here.
Trying to think of the most appropriate place to put something like that in here. Does anybody else seem to have a particular issue when teaching about medical decision making? And
this is Orlando. Are we to add some kind of a law enforcement statement in that thing where in that portion somewhere in the proxy where you can have law enforcement be part of this whole process, or are we?
This doesn't have anything to do with law enforcement. Law enforcement up in our area in general will not help us if an order comes from a physician that they believe the patient doesn't have decision-making capacity, and we get an order to bring them in against their will. We may try to enlist the aid of law enforcement, but they usually don't. I've got one area where they do, but most areas they won't help us. So then the decision is, do we have enough people to safely do it or not? So it's not.
Right.
That statute is not a law enforcement issue. It says a person may. So as a paramedic, when I get an order, I think that changes to shall try at least. But in terms of our law enforcement, they go, yeah, but we're not going to help you do that. This is particularly true when a law enforcement officer thinks the patient's impaired by alcohol. They're out on the street, they're not doing anything else. Somebody is called because they fell down or something. And it's not against the law in Arizona to be intoxicated in public unless you're doing some other criminal activity, trespassing or something. And so now you have an impaired person that can't refuse. They look at that differently than we do. They look at it as a true law enforcement issue, and that it's not against the law to be out here in public. But now we have an issue over whether that person has the capacity to refuse or not. So
I think my recommendation would be potentially to leave that off, because I think unless you have someone that's participated in this meeting or kind of has that knowledge base to really explain how we don't want to now fall back to the term competency, I think we may lose the whole kind of importance of this lecture, which is the ability of EMS clinically as clinical providers to determine capacity. So my thought would be to potentially just leave that off for now, and it could be a teaching point for individuals that understand that and want to include that.
that's fine.
Are there any more recommendations or discussions related to this presentation? There have not been any significant statutory changes related to any of this stuff since it was put out. So really all the changes are sort of just clarifying things.
Amber, do we want to put a different date on that instead of 2017?
Yeah, I'll fix the date. Thank you. Did anybody need to view the changes again, or is there a motion to accept the changes?
So moved, Brian.
Second, Orlando.
Thank you. All in favor of accepting the changes to this decision-making capacity presentation, say aye.
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 Any opposed, say nay. Super. I have a couple more things on here. The next one is going to be, if I could get a motion to discuss the Safe Sleep PowerPoint and Toolkit.
So moved. This is Matt.
Thank you, Matt.
Second, Brian.
Thank you. Okay, so I'll open up the discussion to Julia. If you want to go ahead and let us know about your Safe Sleep PowerPoint Toolkit.
Sure. So the purpose of this toolkit is basically just kind of to provide an overview of safe sleep for first responders, so that if an EMS provider happens to be in a home in a situation in which they could identify a risk factor for unsafe sleep, that they would be able to say something and potentially provide a resource. or some education in that situation. So it's really just kind of more of a resource for if a first responder is in that opportunity to say something. Dale, did you want to kind of add anything or provide any backgrounds?
No, I think that's a good summary. I mean, I think one of the attributes to the toolkit is to allow the EMS agency throughout the state to have access to those resources at all times. So our hope is to eventually have this put on the ADH website, and it is in a CE format. So any agency can use it as a CE toolkit, a module, and implement in their community as they see fit, all voluntary, of course. Thank you.
Do you just want me to kind of scroll through it?
We can't hear you, Amber.
Sorry, muted myself. Yeah, go ahead and scroll through and see if you can kind of highlight some of the important things through the presentation.
Sure. So these are the learning objectives. They're just kind of general, so understand the role suffocation plays in infant sleep-related death. In recent years, the Academy of Pediatrics has really put a focus on suffocation as what we're trying to prevent when we work on safe sleep efforts. So that's the key point throughout our presentation as well. So if we can look at the toolkit after the slides, but there's a pretest in there that is available for use. So we have some data from the EMS annual report in here, and then also from the Arizona Child Fatality Review report. So in 2018 in Arizona, the leading cause of accidental deaths for infants 1 month to 1 year old was suffocation. And so from there, we kind of just go into so more data, what an unsafe sleep environment looks like. So these are the 4 keys that we focused on: sharing a bed with parents, caregivers, or other children, sleeping in a cluttered crib or bassinet, sleeping on their side or stomach, and then sleeping on unsafe sleep surfaces. So we'll give examples of those here, and then go into what the safe sleep environment looks like and include what the safest way to put a baby to sleep is. So basically the opposite of what the unsafe sleep environment looks like: have a separate sleeping space for the baby, place babies to sleep in a crib or bassinet, put babies on their back, and then give them space to breathe, so no pillows, bumpers, etc. And then we included a slide for tribal considerations just to include this if that was something that somebody encountered in the field. So I really just wanted to emphasize that as an EMS provider, the role is to evaluate the baby's safe sleep environment for risk factors, relay information about safe sleep practices, and then identify and refer individuals to resources for safe sleep. Again, we acknowledge that this is not appropriate for every single EMS call. It's very situational and to be used at the discretion of the provider. But those are the rules that we wanted to emphasize, including some resources there. Yes. So that's essentially what the PowerPoint is like. Does anybody have any questions or comments? Okay, I can also go over to the toolkits, which is kind of just meant to be a resource to accompany the PowerPoint slides. So in here we have some different scenarios that could be used in a training class. Also have some frequently asked questions, and then the pre and post test would be in here as well. So FAQs, scenarios, It's like the FAQs might be in there twice, but then the pre-test and the post-test. And some resources.
Awesome. Thank you, Julia. I mean, in looking at this, I think that it definitely would lend itself to particularly those providers that do spend a more significant amount of time in the home, community paramedics, or those that do more home visits or assist in doing safety evals. I think that could be a useful resource for especially those paramedics. Are there any other comments or questions for Julia? So if we approve this PowerPoint and Toolkit today, this will be something we can put on the education page of the DHS website, and it would be available to our providers to use for education. So if there isn't additional discussion or questions, I can take a motion.
Move to approve, Brian.
Sandy will second.
Thank you. All in favor of approving the products here?
Aye.
Aye.
Any opposed, say nay. Okay, and then I'll move on to my last discussion item, which is the training modules table, just as a standing item to review. So on here, highlighted was the one we discussed today. There are 3 others that are sort of a couple years out of date that might need review. I don't know that there's any significant medical changes to these, but there are some resources that that we can review and discuss at the next meeting. If there's anyone interested in reviewing any of these, really the only presentation is going to be the VAD patient presentation. So if anyone's interested in sort of looking through that or volunteering to provide any feedback, you can let Shelley or myself know. And then at our next meeting, we can discuss any recommended changes to those. Or if there are any other additions you'd like to see to this, these training modules.
Amber, this is Gail.
Mm-hmm.
There is one item the Bureau may end up needing to bring this committee together for before the end of the year, and that would potentially be a training curriculum for administration of immunizations. So just something for this group to consider as we get closer to a COVID vaccine. We are trying to make sure throughout the state that we have as many providers as possible who are able to administer vaccines. And so we may end up asking this group just to approve a training for EMS for those agencies that do elect to participate in immunizations.
Mm-hmm. Yeah, so the next meeting would be in March, but you'd want something developed before that, you're thinking, Gail?
I think potentially we would need something done definitely before March, so hopefully by the end of the year or beginning of January. So we will let you guys know, but I know in the past we have had to bring together subcommittee meetings, and Shelley knows all the rules to make sure we stay in line with public rule meetings requirements, but we may potentially just bring this group together to review something.
Okay, thank you for that update, Gail. And I don't have any other action items today. So I'll ask if there are any other agenda items that anyone would like to be considered for the next meeting, other than the one Gail just mentioned, maybe. Hearing none, we'll go on to call to the public. So do I have anything for any of our members or listeners here today? left here anything. So upcoming events, the Bureau's news and conference pages has the upcoming events and CE opportunities. So feel free to take a look at that webpage to see if there's anything upcoming. Our next meeting. Oh, yes, go ahead.
I'm sorry.
Yeah.
This is Shelley. This version of the agenda neglected to have the save the date for the NAMES Pediatric Conference coming up in March. I think March 1 and 2. So I just wanted to put that on the radar.
Names?
Correct.
Okay, thank you. And then our next meeting is going to be the 18th of March. And with that, I'll take a motion to adjourn the meeting.
So moved, Brian.
Second, Orlando.
Thank you, guys. We'll see you guys in a couple of months. Thank you, Shelley and Julia.
Thank you, everybody.